First speaker is Dr. Khalid Al-Waili, who is a consultant, senior consultant, medical biochemist and lipidologist, head of biochemistry department, head of lipid and LDL apheresis unit at Sultan Qaboos University Hospital. He's also the vice president of OSLA, the Oman Society for Lipid and Atherosclerosis. Dr. Khalid will be talking about non-statin therapies for hyperlipidemia. Over to you, Dr. Khalid.
Thank you very much for the nice introduction. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everybody. So my presentation today will be about non-statin therapies for hyperlipidemia. And as you know, in case of lipidology, the statins used to be the mainstay treatment for hypercholesterolemia. But in the recent last decades, there were so many discovery of so many useful medications, and there was a challenge to see which one really does reduce cardiovascular events. Because at the end, it's not only the reduction of the LDL cholesterol, it is the reduction of cardiovascular events. So these are my disclosures. So now we have really evidence and we have data over the last few decades that LDL cholesterol plays a causal role in atherosclerotic cardiovascular disease. And most importantly that if you see the higher the LDL cholesterol, the higher the risk for cardiovascular disease. This slide summarizes the relationship between the LDL cholesterol and cardiovascular disease in 3 different studies. If you see the red line, randomized controlled trials, and usually these are over 5 to 7 years. And then if you see the gray line, prospective cohort studies, and usually with a median follow-up of 12 years. And then most importantly, you see the Mendelian randomization studies, and this is a lifelong study to give you the exposure over the whole life of the patient. So if you see the relationship between the LDL cholesterol and cardiovascular events, you would see that relation is really more steep with the Mendelian randomization studies. And these studies, they really study the genetic polymorphism. And then it will give you the idea about the whole life exposure to the LDL cholesterol. Okay. So now we know that LDL cholesterol, when it is really in a high concentration, is really very bad for our health, for cardiac disease. But the good thing that LDL cholesterol reduce the cardiovascular events. And if you see from these trials, whether it was a primary or secondary placebo-controlled trials, you would see that statins, they were very effective in reducing the LDL cholesterol, and more importantly, in reducing the cardiovascular events. And then in later studies, the higher the dose of a statin, the higher the reduction of LDL cholesterol resulted in a higher reduction of cardiovascular events. And then now this question, if statins are proven to be effective and they reduce the cardiovascular events, then why do we need to continue developing lipid-lowering therapies? So let's go back to the placebo-controlled trials for statins. Yes, they are very effective in reducing LDL cholesterol and, more importantly, the cardiovascular events. But if you would look at the best studies and the best reduction of cardiovascular events, you would see the best one will give you 45% reduction in cardiovascular events. So what does this mean? It means that still there is 60 to 70% of those cardiovascular events are not yet protected. And then that's why actually we need another medication. But if we go back to these statin trials, why does this happen? Why do we have only up to 40-45% reduction in cardiovascular events? Some patients, they have suboptimal treatment, and many patients, they are not really compliant with statin, whether they have true statin intolerance, or actually they have what we call it a placebo or nocebo effect. Another issue, sometimes you might have a refractory hypercholesterolemia. So the patient taking statins, and they have a response only 20 to 25%. So they are statin resistant. Another subset of patients that we will talk about today, 3 important groups: patient with familial hypercholesterolemia, high cardiovascular risk and other metabolic disorders, even if you give a high dose of statin, still you will not reach the target of LDL cholesterol. If you go to familial hypercholesterolemia, they start with LDL cholesterol of 10 millimole, 8 millimole. So even with the strongest statin, high intensity, with the highest dose, it will give you 50% reduction. However, 50% reduction from LDL cholesterol of 10 to 5, that's still high. Again, patient with very high risk category. You would see in the latest guidelines that we need a target 1.8, very high risk 1.4. And those targets cannot really be met by statin alone. So that's why we need another medication. And then statin intolerance patients, of course, they cannot take statin whether it was partial intolerance or complete statin intolerance. Then you would need another medication. And the last group, we will touch in some type of patient, diabetic, metabolic syndrome, and obesity. We might also touch why we need another medication briefly, but Dr. Nasreen Sayed will talk about it more in her case discussion. So now if we go to what are the available non-statin therapies. All the guidelines, all the treatments, the first line treatment will be lifestyle modification and statin. But next, what are the available treatments? So after statin, I will discuss both medication and I will try to categorize them into oral medication and injectable medication, and we will see how much they would reduce LDL cholesterol, and more importantly, which one does reduce cardiovascular events. So this list of medications can be summarized in one graph where you will see the mechanism and the site of action of this medication. So if you see statins and bempedoic acid, they really work on the pathway of cholesterol synthesis. So they would decrease and inhibit cholesterol synthesis in the liver, and that would result in a higher upregulation of LDL receptor at the surface of the liver. Lomipitide is really working also on the liver by inhibiting microsomal triglyceride transfer protein, and this is a very important protein to assemble the VLDL particles, which later on will be transferred into LDL particles. So by inhibiting this transfer protein, you would limit the synthesis of the VLDL, and then you would have a less VLDL available in the circulation, and then consequently less LDL cholesterol. Then we have a group of medications that anti-PCSK9 monoclonal antibodies and inclisiran, where one of them would inhibit synthesis of PCSK9, the other one would really block the PCSK9 from its working, and the PCSK9 is the one that's responsible to keep the number of LDL receptors in our liver, and it really degrades the LDL receptors. So by inhibiting the PCSK9, we are inhibiting the degradation of the LDL receptors, and then you would have more LDL receptors at the surface of the liver and more clearance of LDL particles. Then we have another two new medication, the NGBT3-1 inhibitors, and this is an inhibitor of lipoprotein lipase. So if you would inhibit the inhibitor of lipoprotein lipase, then we are increasing the catabolism of VLDL to IDL and LDL, and then more clearance of LDL particles. And then, yeah, so these are most ones. So I'll go them quickly one by one, and most importantly, we'll see how they are effective in reducing LDL cholesterol, and more importantly, are they effective in reducing cardiovascular events? So the first treatment, it was a statin proven to be effective and reduce cardiovascular events. After that, if you see in 2002, we have ezetimibe. It was approved by FDA. And then I'll show you later on the studies that's also reducing the cardiovascular events. And then in 2012-13, we have the approval of lomipitide, that is the MTTP inhibitor. And then in 2015-16, we have the PCSK9 monoclonal antibodies. And then if you see up the Fourier and the Odyssey trials are the outcome trials that they proved that PCSK9 monoclonal antibodies, they reduce LDL cholesterol and more importantly, cardiovascular events. And now we have more of inclisiran and bempedoic acids. Bempedoic acid already we have the outcome trials. For inclisiran we are waiting the outcome trial. It will be around 2026. So if we start with ezetimibe, so how does it really work? So ezetimibe, it inhibits the Niemann-Pick C1 like 1 receptors that is really responsible for cholesterol absorption. By inhibiting the NBC1L1, then you inhibiting the cholesterol absorption. It's very effective, and it reduces LDL cholesterol by 20 to 25% on top of a statin. And this then this is a cheap medication. It's taken orally, and then you would consider it if you would need a further reduction on top of statin up to 25%. Do we have evidence that it reduced cardiovascular events? Yes. So we have improved trial, and also we have a sharp trial. So in improved trial, you would see that there is a reduction in the cardiovascular events by almost 16% when you give it on top of a statin. So now we have ezetimibe. It is very effective. It reduces the LDL cholesterol, and more importantly, it reduces also the cardiovascular events. And it can be given to a patient whom they don't reach the target, and you need a further up to 20-25% more reduction on top of a statin. Another thing with the ezetimibe, if you have a patient who cannot tolerate also a high statin, and many patients, they would like to avoid a high dose of statin. What if we combine a moderate low dose of statin with ezetimibe instead of a high dose of high intensity statin? Is it similar? Is it superior? Is it inferior? So if you see from this trial that combination of a moderate intensity statin plus ezetimibe compared to high dose of high intensity statin will give you more or less the same results in terms of reduction of LDL cholesterol and reduction of cardiovascular events. So adding ezetimibe to a moderate dose of statin is really non-inferior to a high dose statin. And this can be given really to any patient with partial statin intolerance, or any patient is not really willing to take a high dose of high intensity statin. There is also a bile acid sequestrant. It was for a long time available in the markets. It's really effective in reducing LDL cholesterol by 12 to 20%. And it was also shown that it reduced cardiovascular events, and it is really safe in children and in pregnant women. The only reason why people, they don't use it is they have so many gastrointestinal side effects, and it's really limiting the use of this medication. Many patients, they were really hesitant to be started on bile acid sequestrants, especially with the discovery of the latest medications. Bempedoic acid is another new discovery for anti-hyperlipidemia, and it works on the same pathway of statins. Statin, they inhibit HMG coenzyme A reductase. That's the rate-limiting step in cholesterol synthesis. But bempedoic acid, it inhibits ATP citrate lyase. This is an enzyme before and upstream of the HMG coenzyme reductase. And they are very effective. They reduce LDL cholesterol by around 16 to 20%, and they are very effective. And this can be really considered, especially in patients with statin intolerance, or nowadays you will see later on in the latest guidelines that can be even combined with the statin and ezetimibe if you need a big reduction and patient, they want to avoid injectable therapy. Do we have any evidence that they also reduce cardiovascular disease? Yes. So from the outcome trial, it was the clear outcome trial, you would see that the adding bempedoic acid on top of statin, they reduce cardiovascular events. And if you see it, they reduce by around 22% LDL cholesterol, and they reduce the cardiovascular events by almost 13%. So now after statin, we have ezetimibe and we have bempedoic acid. They are oral therapy proven to reduce LDL and, more importantly, cardiovascular events. Now, after discovery of bempedoic acid, people, they start asking, can we combine it with ezetimibe, especially for patients with statin intolerance, whether it was partial or complete statin intolerance? And if you see from this trial, yes, adding bempedoic acid with ezetimibe, whether alone or on top of statin, you would see that if you add ezetimibe to statin will give you 23%. Bempedoic acid added to statin will give you 17% reduction. But adding both together on top of statin, it would give you really another 36%. Then now it gives you really a more wide range of variety of medication, orally taken medication that reduce also cholesterol and cardiovascular events. Now, before we go to the injectable therapy, let us revise what are the available oral anti-cholesterol medication and their efficacy and how much they reduce LDL cholesterol. So if you see moderate intensity statin give you 30% reduction and high intensity statin give you 50% reduction. If you add a low dose statin plus ezetimibe, it give you up to 40% reduction. Bempedoic acid and ezetimibe alone, they give you another 45% reduction. But look at the last one. Any patient who is not really willing to take injectable medication, then you can combine high-intensity statin plus ezetimibe plus bempedoic acid. That will give you up to 70% reduction on LDL cholesterol. Now let's move to injectable therapy, and then we would summarize everything together in terms of all the medication. So we have actually 2 medication for monoclonal antibody and 1 medication as inhibitor, siRNA-based therapy to inhibit the synthesis of monoclonal of PCSK9. What is PCSK9? PCSK9 is available in the liver, and it reduces the amount of LDL receptor available at the surface of the liver. So by inhibiting PCSK9, whether by monoclonal antibodies or by inhibiting the synthesis of the PCSK9, that would result in a low PCSK9 and higher LDL receptor at the surface of the liver. And higher LDL receptors, then it means high clearance of the LDL particles and the LDL cholesterol. So we have 2 medications available. We have alirocumab and evolocumab. Both of them, they are giving sub-Q injection every 2 weeks. Evolocumab can also be given once a month, depending on the dose. And they are really effective to reduce LDL cholesterol by almost 50% reduction. Then if you remember when we talk about ezetimibe, you would add ezetimibe if you need only up to 20-25% reduction. But if you need more than this, especially you need 50% reduction, then PCSK9 monoclonal antibody, they are the one to be considered. They give you up to 50% reduction on top of a statin. Do we have evidence from a clinical trials that they reduce cardiovascular events? Yes. If you see the Fourier study and the Odyssey study for alirocumab and for evolocumab, you would see that both of them, they reduce the cardiovascular events almost 15% when they are added on top of statin therapy. So yes, they are effective to reduce LDL cholesterol, but more importantly, they reduce cardiovascular events. Another medication, injectable, is inclisiran. This is the latest of the PCSK9, and it is siRNA-based therapy. So it is a small interfering ribonucleic acid that silences the translation of the PCSK9 messenger. So it would lead to lower production of the PCSK9, and then it has to be really administered only twice a year. So this is the beauty of inclisiran over the PCSK9 monoclonal antibody that can be given every 6 months. Only the first year you have to give a loading dose, so day 0, after 3 months, 6 months, and then if it is every 6 months. Both of them, monoclonal antibody and inclisiran, more or less, they give you more or less the same reduction in terms of the LDL cholesterol. Then you might consider inclisiran if your patient is not really willing to take monoclonal antibody every 2 weeks, because monoclonal antibody has to be given every 2 weeks. This has to be given every 6 months. We don't have yet the outcome trials. It will be really published in 2026 or maximum by 2027. So that will be the outcome trials. So it was shown that it reduced PCSK9, and then that was translated in a reduction of the LDL cholesterol. We have another 2 medication, and then the LDL apheresis, and these are really meant for homozygous familial hypercholesterolemia The first one I will start with is evinacumab. So evinacumab, if you remember from the graph, we have a lipoprotein lipase that it's really responsible for degradation of chylomicrons and VLDL, and then from VLDL to IDL and LDL. So evinacumab is really, it's inhibiting act to inhibit the inhibitor of this lipoprotein lipase, and it was really shown very effective in the reduction of the LDL cholesterol, and it really, the reduction was up to 50% reduction in the LDL cholesterol. And now it is approved as an adjunct therapy for homozygous familial hypercholesterolemia. Lomipitide, it was also before the evinacumab, and as I mentioned in that graph, it is a microsomal triglyceride transfer protein inhibitor, so it would inhibit the synthesis of the VLDL particles that would result in a very low LDL particles in the circulation. And it was also very effective in reducing LDL cholesterol, and it reduced LDL cholesterol between 40 to 50%, and it is also approved for a patient with homozygous familial hypercholesterolemia, whether alternative to LDL apheresis or also in top of LDL apheresis to reduce the frequency of the LDL apheresis. The last one I will talk, the modality, briefly, the LDL apheresis. This is the standard of care for homozygous familial hypercholesterolemia. It works by absorbing the VLDL and LDL particles from circulations, and it reduces LDL cholesterol up to 60 to 70% in the circulation. Now, if we go back to that table and summarize oral and injectable therapy. So this is the beauty now. You have more than 5-6 medications, oral medication and injectable medications. If you remember, high dose intensity and ezetimibe 65, moderate statin, ezetimibe, bempedoic acid 65, high statin, ezetimibe, bempedoic acid from the previous graph 70%. The same thing see for PCSK9 inhibitor plus high intensity statin plus ezetimibe will give you 85%. So if you start with a patient with LDL cholesterol of 12 and you would like to have the LDL cholesterol around 2, 1.8, then there is no way except with the combination, the last column. Now, after these trials and after the outcome trials, we don't have yet the outcome trial for the inclisiran. It will be coming in 2026. All these trials, they really inform the guidelines. And if you see the latest guidelines, the 2019, you would see that there is a very high risk group. So in 2019, the first time we see a high risk group in 1.4, but before that, the American Association of Clinical Endocrinologists, they also released their guidelines, and you would see they put the 1.4 as a high risk, or they call it extreme risk in their guidelines. How can we get to 1.4 with statin only, especially in patients with familial hypercholesterolemia, patient with very high risk, and patient with statin intolerance? And that's why after the 2019, they came up with 2023, which I will show you later on after this slide. But even in 2019, they said no way in some patient you start with a stepwise treatment. You start with the statin, 3 to 6 months, then you add ezetimibe, 3 to 6 months, then you add either bempedoic acid or PCSK9 inhibitors. No. From the first visit, you have to evaluate your patients and see what is the baseline LDL cholesterol, what is your target, whether it was 1.8, 1.4, or 2.6. And you calculate what is the baseline to your target, what is the reduction needed, what is the percentage reduction needed, and then you refer to that table, which also they summarize it here. This is actually the previous one, but there is a more updated one, the one that I showed you previously. Then you have oral medication and injectable medication. You have to choose the right combination from the beginning. And that's why in 2022, the European Society of Cardiology, they issued another consensus statement. I just took this graph from them. Combination lipid lowering therapy as first-line strategy in very high-risk patient. So it's no more in high-risk patient to start statin, then add ezetimibe. No, from the beginning, you have really to start with the combination therapy. Another, actually, publication was published this year, 2 months back, by Albrico Catabano, one of the also people in the European. 2 minutes? Okay, I'll try to do it fast. They came up actually with the same consensus that you have to start with high-intensity statin, ezetimibe, then in their guidelines they would like to add bempedoic acid, and then you can also go for quadruple therapy. But what I liked in that actually article, I will not go through it in detail. Now you have 6-7 medications. Which one you would start with? You have really to take into account the clinical aspect and the pharmacokinetic aspect of those patients, and you have to see which medication suit those patients, whether pediatrics, whether pregnant women, whether there is a drug-drug interaction. The last point, I will do it quickly, it will be covered by Dr. Nasreen Al-Sayed in her presentation. We have another subset of patients that they still, even if you reduce LDL cholesterol, they have a high risk of cardiovascular disease. Those are diabetic metabolic syndrome and insulin resistance. And if you see, even if you reach the LDL cholesterol target within them, the non-HDL cholesterol still not reach. And that's because of triglyceride-rich lipoprotein particles. And is it triglyceride or is it something else? Actually, it turned to be, it's not only the triglyceride by itself, it is really by the remnant cholesterol carried within these triglyceride-rich lipoprotein particles. And if you see, even the LDL is normal, but the total non-HDL cholesterol is very high. And then we have the latest trial by the REDUCE-IT trial, where they compared the ecopentathyl, the EBA alone, not the combined EBA and DHA, and it was very successful to reduce the cardiovascular events by 25%. And if you see on the latest update also by the European Society of Cardiology for patients with diabetes, the same high risk 1.4, but they added really also the non-HDL as a target with those patients high risk and very high risk. And just what I wanted really to tell you, that statin is still the first line treatment, followed by ezetimibe and PCSK9, but more importantly for triglyceride, now they put only EPA, okay?
Can you conclude?
This is the conclusion. So to conclude my presentation.
We have a prayer.
Sure.
Time, sorry.
So lowering LDL cholesterol level is really the most important pharmacological intervention to mitigate atherosclerotic cardiovascular disease. Yes, statin is still the first line treatment, but on those patients with FH, high risk, and other patients, you really now have to start combination from the beginning. Thank you very much for listening.
So thank you very much, Dr. Khalid Wiley. Really, it was very insightful into the talk of statin and non-statin therapy. I would like really to extend my thanks to GAD organizer committee and also GAD scientific committee for this really putting all this excellent scientific program. So before also moving to our next speaker, I would like just to remind you, please, after this session, there will be a satellite symposium session. So we hope by 11:55 will be finished, and there will be a transport for Jumu'ah prayer. So you don't worry, you don't have to rush and leave the room. So our next speaker is Professor Masiji Banakh, and he's a good friend of mine, and I know him very well since long time. So he is the Secretary of the European Atherosclerosis Society. He is also the President of International Lipid Expert Panel, and I advise you really to join this excellent task force. And also he is the President of Lipid Association at Poland, and he is also the Editor-in-Chief of Archive of Medical Science Impact Factor of more than 3. So whoever interested also in research, I'm sure Prof. Masih Banakh will be happy to to help. And this is your first visit to Oman?
Yes, it is the first time, yeah.
So welcome to Oman, and hope this will not be last. We have an international congress in December 2024 with the International Atherosclerosis Society, and we hope to see you there also. Thank you.
Thank you so much, Khalid. Thank you so much, dear Chairman, dear ladies and gentlemen. It's a great pleasure to be in Oman, in Muscat for the first time. And with my second lecture yesterday afternoon, I spoke about the statin-intolerant management. Now I would like to convince you, after a beautiful presentation by my colleague about the summary of the non-statin therapy, that these non-statin therapies might help us to personalize the treatment of patients with lipid disorders for the first time. In fact, something we have for patients with hypertension, diabetes, and so on. So these are my disclosures. We know it very well. It is something that we cannot overcome, in fact, that cardiovascular diseases are the most important cause of death worldwide. As you can see, these slides from the WHO, as well as Global Burden of Disease, University of Washington in Seattle, the largest ever group of people working on with about 4 billion patients' data. We know it very well that cardiovascular diseases are responsible for about 21 million of deaths after post-pandemic time or in pandemic time. And the good thing is that 2/3 of those deaths are due to atherosclerotic cardiovascular disease. So these are preventable. So it is our choice now, and it is our role in order to prevent them suitable. What is more, if we would look at the number of cases of diabetes, as you can see, the same group of global burden of disease, in 2021, there were over 524 million people with diabetes worldwide. And there is a prediction to have about 1.3 billion people with diabetes by 2050. So it is our role now, in order to be effective with the treatment diabetes and concomitant disorders, including lipid disorders. Unfortunately, for many patients, lipid disorder is not treated well. And in diabetic patients, unfortunately, this is the group of patients which have lipid disorders ignored, because we are focusing obviously on the glucose control, on hypertension control, but do not think about atherogenic dyslipidemia, which is the most common and most preventable risk factor in this group of patients. You know it very well, based on the many different trials, that diabetes itself increases the risk of cardiovascular disease. And if we have patients at a very high cardiovascular disease with diabetes, in fact, take into account our definition we introduced in 2021, it can be a patients which might be defined as extremely high-risk patients. What is more, in this group of patients, for example, if we look at the results from the Improve It, you remember that it was with the Improve It, we have a 6.4% reduction of the main cardiovascular outcomes. But when we add diabetes for those patients after ACS, the reduction was 14%. So the higher risk we have, the better reduction with the intervention we might observe for all of our patients. It is a much more complicated figure that my colleagues presented about the different opportunities we have now when we treat lipid disorders. It is amazing. We are living in amazing times, because I remember the times when we had only statin or by acid sequestrants, which were very rarely used. But on the other hand, since 2002, we have ezetimibe. Since 2012, 2013, we have PCSK9 inhibitors and many other different drugs, also in perspective, such as obesity therapy, oral PCSK9 inhibitors, and many others, olezarsen, volanesorsen, vupanorsen, and many others. So now, in fact, the main message based on this quite complicated figure is that the rare diseases should be lipid disorders should be rare diseases, in fact. So most of our patients should be on the goal of the therapy, having very effective statin therapy, which should be a gold standard, plus non-statin therapy, and the combinations, which I would like to convince you is the best choice for most of the patients at a very high cardiovascular risk. But let's start with statin. Here is a beautiful paper published recently on how to proceed and manage patients with familial hypercholesterolemia by the International Atherosclerosis Society. And as you can see, we have now 3 high-intensity statin therapies with atorvastatin, rosuvastatin, and pitavastatin finally. In fact, I do not understand why for many years pitavastatin was mainly available in the Asian countries, in Japan and many others, and wasn't available in Europe, mostly in Europe and other countries. Especially it is a statin which is a little bit different in comparison to other statin, taking into account its metabolic properties as well as its safety. I would like to convince you, especially in the relation to the personalized approach to diabetic patients. What about, well, let's have a look whether pitavastatin is effective in diabetic patients, and it might reduce even atheroma plaque volume. It is one of the study, Japan ACS, that showed that in patients with diabetes, we might observe significant reduction of plaque volume in those treated with pitavastatin. So we have another drug as an add-on to atorva and rosuvastatin and reversal and arbiter trials when we have another statin therapy that is effective in the reduction of the atheroma plaque. What is more, you know it very well that diabetes, prediabetes, metabolic syndrome, chronic kidney disease these are those conditions when we might observe atherogenic dyslipidemia, which is very, very important condition that might be associated with significant increase of cardiovascular events. Pitavastatin is the statin that not only has the highest potency to increase HDL cholesterol. I don't want to focus on HDL cholesterol because it is probably it would be another lecture, because you know it very well about the dysfunctionality of the HDL cholesterol. I'm investigating this issue for the last 20 years. But also, is the highest potency to reduce triglycerides. So those two important components of the atherogenic dyslipidemia. What is more, we always expect that the drugs for diabetes that should not interfere with glucose and hemoglobin A1C. And please have a look at the pitavastatin. Pitavastatin is a little bit outside of the class effect of other statins because it might reduce even hemoglobin A1C and glucose level, baseline glucose level. And we know the mechanism because the mechanism is associated with the inhibition of the phosphatidylcholine inositol kinase. So pitavastatin is responsible for changing of the glucose into glucagon in the liver. So it is critically important. It's completely different to other statin which we have on the market. And that is why, based on these, we might observe reduction or lack of increase of baseline glucose level as well as hemoglobin A1C in our patients treated with pitavastatin. And that is why you may see the largest meta-analysis that was published in 2015, in which it was shown that pitavastatin itself is not associated with new onset diabetes. It is probably one of the most important messages, because sometimes there are many colleagues, physicians that are afraid of using statins due to the fact that they are saying, oh my goodness, I'm not sure whether I should use high-intensity statin therapy because it might be associated with the new onset diabetes. We know it very well that this association is 5 times less than the potential of statin to reduce cardiovascular outcomes. But on the other hand, now we have a possibility to personalize the treatment in those at the risk of diabetes, with the prediabetes, for example, as well as in those with diabetes, to use pitavastatin or pitavastatin with the combination because it might help or improve anti-diabetic treatment. My colleague beautifully said about the upfront lipid-lowering combination therapy. The main point when we introduced it for the first time in the world by the International Lipid Expert Panel in April 2021 was the fact that we've noticed that we are not effective at all with the high-intensity statin therapy because high-intensity statin therapy is underused, because it is used in only 1/3 of our patients at a very high cardiovascular risk, and we mostly use moderate intensity statin therapy in 50% of our patients. And we know it very well that since 2017 we have a generic ezetimibe, and that is why it is very cheap. And we have a fixed dose combination of ezetimibe and high-intensity and statin therapy. That is why we have finally the option to use statin and ezetimibe for our patients at a very high cardiovascular risk. And that is why in 2021 we said, for very high-risk patients with established atherosclerotic cardiovascular disease, especially after acute coronary syndrome, in those with familial hypercholesterolemia, in those with statin intolerance, please immediately start with upfront, so immediate combination therapy of statins and ezetimibe, especially if the baseline level of LDL cholesterol is over 120. Why? Because we know it very well that assuming 50% reduction of the LDL cholesterol with statin therapy, having LDL cholesterol 120 and over, we will be still over the target of 55, so 1.4 millimole per liter. But it was the beginning, but in the February 2022, with the group of experts, so my colleagues from the European Atherosclerosis Society, we make a step forward, and we said maybe not only for these groups of patients, but for all patients at a very high cardiovascular risk, we should consider upfront combination therapy to be on the target as early as possible, as low as possible, as long as possible. What is more, we also introduced for the first time that probably for the extremely high-risk patients, and these are not only those patients with 2 events, vascular events in the last 2 years, but also we introduced those patients after ACS with peripheral arterial disease, those with ACS with FH, those with ACS with diabetes. We said start with the triple therapy to be on the target as low as possible, as early as possible. Obviously, there is one limitation because in many countries, in fact, PCSK9 inhibitors and inclisiran are within the reimbursement drug program, and it is impossible simply to start with the immediate PCSK9 inhibitors because we need to wait for the results of the treatment of statins and ezetimibe simply for 3 months. Okay, why it is important? It is only a confirmation of the presentation which has been already made. Please notice that we now may have 99% of our patients on the LDL cholesterol target, hypothetically, obviously, because there are many reasons that our patients are not on the target. It is not adherence, these are many availability of the drugs and so on, but it is also our physician's inertia. These are our mistakes we are doing, and we need to admit that about 30% or even 40% of the failure in the treatment, it is due to our fault. But what we can do, in most of the patients at a very high cardiovascular risk, we might use combination therapy. And please have a look that even with the LDL cholesterol up to 400 milligrams per deciliter, that's a baseline, using triple or 4 drugs in the combination, we might be on the target below 55. So even in those patients with complete statin intolerance, using ezetimibe or bempedoic acid and ezetimibe with fixed dose combination, assuming 40% reduction, and plus PCSK9 targeted therapy approach, so PCSK9 inhibitors and inclisiran, we might have 80% reduction of the LDL cholesterol, so 95% of those patients might be on the target. But we are not using these options. Okay, the racing trial has been already mentioned, but the racing trial has one limitation. Please notice that in the racing trial, they are using rosuvastatin 20 or rosuvastatin 20 and ezetimibe. And the authors said, it is a beautiful paper, I love it very much, but they said that there is no difference taking into account the reduction of the cardiovascular outcomes, but there are significant difference in the number of patients being on the target with combination therapy, and much less patients with the discontinuation of the treatment, and with much less patients with the adverse effects in comparison to the high-intensity statin therapy in monotherapy. But why they were using 20 milligrams of rosuvastatin in very high-risk patients? This is something that we've noticed in many trials after the racing. For example, in one of the trials I will show you in a minute, based on the Polish ACS registry. It appeared that when we started ezetimibe, about 25% of the patients reduced the dose of statin. Why? If there is no statin intolerance, if there is no statin-associated muscle symptoms, why we are reducing the dose of the statin when we add ezetimibe if you would like to increase the number of patients being on the LDL cholesterol target? It is difficult to explain. So that is why please do not de-escalate the treatment when you add ezetimibe. Obviously, there are cases of the statin intolerance, there are cases of the risk of the new onset diabetes when it is possible. But in most of our patients, do not de-escalate the treatment if you would like to have your patients on the LDL cholesterol target. And we have obviously the sub-analysis of the racing trial that clearly showed that for the patients, for the elderly patients as well as those patients with diabetes, using of the upfront lipid combination therapy is associated with the insignificant reduction of the cardiovascular outcomes, but also with much less patients that discontinue the therapy and much less patients with the intolerance to therapy. So it is much better in comparison to high-intensity statin therapy. Okay. I've told you that for most of our colleagues, when we introduced the recommendation of the upfront lipid-lowering combination therapy, they said, okay, if you are so clever, give us the data it really works. Okay? Obviously, we might say that if we reduce LDL cholesterol, in the consequence, if we are more on the target, in the consequence, we might have more and more patients with the reduction of the cardiovascular outcomes. But okay, if you are so conservative in your approach, please have a look at our data we published in September this year based on the 1 million patients from the Polish ACS register. We simply, in patients after ACS, we compared patients treated with high-intensity statin therapy in comparison with the upfront combination therapy of high-intensity statin therapy and ezetimibe. And please notice that only after 52 days, we were able to observe significant reduction of all-cause mortality, and after 3 years, 47% reduction of all-cause mortality with number needed to treat 21. So if you need more evidences, I cannot give you. It is probably the strongest evidence ever. At the same time, the colleagues from South Korea also published additional important study based on the inclusion criteria from the racing, but it was an observational cohort study which showed the same, 25% reduction of the all-cause mortality and cardiovascular outcomes in patients treated with upfront lipid-lowering combination therapy. And finally, after 2 years, we were so happy to see at the Congress of the European Society of Cardiology in Amsterdam that for the first time in the European guidelines, it is set with A, 2B class of the recommendation. I may argue with this class of recommendation, but it is less important. It is an important step forward that for patients after ACS, we might consider upfront lipid-lowering combination therapy as a treatment, as a recommended treatment. Very important step forward. So you have now in the guidelines that for very high-risk patients, you should always consider upfront lipid-lowering combination therapy to reduce the risk of those patients. Okay, this slide was also presented by my colleague, but it's a very good slide, and that is why I'm not so surprised. But we have finally some drugs that might add additionally for us to be effective with the LDL cholesterol reduction. Bempedoic acid is a beautiful drug. It is the same pathway as it was already mentioned, but it is something very important. It is a pro-drug in the muscle. So from the very beginning, we might have assumed that it will be a beautiful drug for all the patients with non-adherence with statin-associated muscle symptoms. It was really the truth. But on the other hand, please do not classify bempedoic acid only for statin-intolerant patients, because we have a beautiful data from phase 3 trials. I was involved for all of those trials, that for patients with heterozygous FH, with atherosclerotic cardiovascular disease, it might be very effective in the reduction of the LDL cholesterol by even 27%, but also taking into account the inhibition or activation of AMPK kinase, it might also reduce CRP. So it is another drug that might have a potency to reduce hsCRP by even 40%. Do we have a data for this? Obviously. It is our meta-analysis we published before CLEAR Outcomes, in which also it was showed that it might reduce new-onset diabetes by 40%. So it is another drug you might use to personalize the treatment of patients with diabetes, because it might reduce new-onset diabetes and it might reduce the clinical outcomes. Do we have a data for this? Please have a look at the results of the CLEAR Outcomes. In the CLEAR Outcomes, we have a beautiful presentation of the patients with diabetes 45%, which what we showed, it was presented at the ACC Congress in New Orleans, it was 21% reduction of the LDL cholesterol, only 21%, in statin-intolerant, very high-risk patients, was associated with the 13% reduction of the cardiovascular main endpoint and 23% reduction of the fatal and non-fatal MI. Amazing, 21% reduction of the LDL cholesterol has such a beautiful results in cardiovascular outcomes reduction for these very high-risk patients. That is why at the same time, we simultaneously published data by the International Lipid Expert Panel recommendation how to use bempedoic acid in those patients. So in the patients at a very high cardiovascular risk, depending on the baseline level of LDL cholesterol, you might start with upfront lipid-lowering combination therapy of statins and ezetimibe, start with bempedoic acid, and then only for about 15% of patients, 1/5, if we would be effective at PCSK9 inhibitors and inclisiran, because with those three drugs, high-intensity statin therapy, bempedoic acid, and ezetimibe, we might be on the target with even 75 to 85% of our patients. Okay, what about these beautiful results concerning lack of the new onset diabetes with bempedoic acid? If you ask me about the mechanism, we do not know how it works. Really, we are working on each take into account the experimental data. But if you look at this, especially in those patients with diabetes and prediabetes, using of the bempedoic acid is associated with the significant reduction of the new onset diabetes and more patients being on the hemoglobin A1C below 6.5%. Okay. The same results when in fact confirmed during the ACS, during the European Society of Cardiology Congress in Amsterdam, and especially you can see that in those patients with diabetes, there was a significant reduction of cardiovascular outcomes when we used bempedoic acid. What about the recommendation? In our paper by the International Lipid Expert Panel, based on those results, we said, bempedoic acid may be considered in patients at a high and very high cardiovascular risk with prediabetes and diabetes to reduce the risk of new onset diabetes and improve glycemia. So you have another drug to personalize the treatment of those patients. About the PCSK9 inhibitors, you know probably everything, but I don't know if you know that they have the same efficacy in those patients with diabetes and without diabetes concerning LDL cholesterol reduction. But if we look at the results on the MACE risk reduction in those patients with diabetes and prediabetes, due to the fact that diabetes increases the risk, we might observe higher reduction of cardiovascular outcomes in comparison to those without. And it was the same for, obviously, for evolocumab. But one thing is critically important for you to remember, that PCSK9 inhibitors, as well as inclisiran, do not increase the risk of new onset diabetes. So these are natural concerning the risk of new onset diabetes. So again, these are another drugs that you should always consider when you personalize the treatment of patients with diabetes. What is more, we know it very well that we have already the data, long-term data with PCSK9 inhibitors that confirm that the longer the better if we treat our patients. Please have a look at the results of the Fourier-Ole. You remember the Fourier, we have a problem with cardiovascular mortality which was insignificantly reduced. In Fourier-Ole, we have a significant reduction of the cardiovascular mortality, so the longer the better for the treatment of very high-risk patients. And obviously, we are waiting for the results of the inclisiran, especially for the Orion 4 and Vectorion to prevent studies. But on the other hand, we might predict about the 15 to 25% reduction of cardiovascular outcomes, especially it is associated with the, I can see the time, yeah? It is associated with the improving of adherence. So, it is my last slide. So taking all together, to summarize, as you can see now in 2023, based on our recommendation published in 2022, we might have a personalized approach to those patients with diabetes, how to be effective, not only in the reduction of the cardiovascular in the LDL cholesterol, but also not to increase the risk of new onset diabetes and to improve anti-diabetic treatment. Thank you very much.
Thank you, Professor Banach. I think as chairpersons go, myself and Professor Khalid will need to be a bit strict, so our apologies. I'd like to present our next speaker. Dr. Nisreen Sayed, consultant endocrinologist and lipidologist, also the chief medical officer of Dar al-Sahha Medical Center in the Kingdom of Bahrain.
Thank you very much for the kind introduction. I would like to thank my colleague speakers for their excellent talk, and they set really excellent basis for my cases right now. So just bear with me and focus, because I'm going to go really fast. I don't want you to miss all the cases that I have. These are my disclosures. So let's start with case one. So the first case is going to be about primary prevention and patients' perception of statin therapy. So Ms. Wafa is a 52-year-old female with history of hypertension, BP 142/86 on amlodipine, and history of mixed dyslipidemia while taking pravastatin 20 milligram. So her lipid profile on pravastatin 20 milligram, LDL cholesterol, I'm showing it to you in milligrams and millimoles, but I'm going to say the milligrams. So she has an LDL cholesterol 110, HDL 49, triglyceride 185. She reports that she didn't feel good on atorvastatin 40 milligrams. She was offered that previously and is hesitant to try a third statin. She also states they can cause diabetes and is concerned that the statin putting her at a higher risk of diabetes because of her family history. She's not keen to continue or change to any form of statin because she hears that they can cause side effects. Typical patients that you see in clinical practice. Other lab profiles showed a fasting blood glucose of 110, A1C 5.9. She had normal kidney function, liver function, and her BMI was 31. Waist circumference 91.5. She denied smoking, alcohol, and she walks 3 times per week. You calculate her risk score. You do like 3 calculations. You do a calculation based on the ACC-AHA risk score calculator, and it is turned out to be 7.8%. Q-risk calculator turned out to be 4%, and score calculator, according to the European guideline, she's 3%. She has family history. Both parents developed type 2 diabetes and ASCVD in their early 60s. So the questions are, is statin necessary in this patient? She comes to you, she's already on pravastatin, and she would tell you, do I really need to take statin? What is the acceptable or target LDL for this patient? And finally, how would you address the patient's statin-related safety concerns? Most of the patients have these concerns. So, looking at the ACC-AHA guidelines, this patient is not an established cardiovascular patient, she's not diabetic, and she's not a case of FH, as far as we know. But she is a case of primary prevention. So according to the guidelines, you need to calculate her risk. And looking at her risk, she is calculated as 7.8%, which puts her at the intermediate risk group. So according to the ACC-AHA, if you have this kind of risk calculation, you need to look at risk-enhancing factors as well, shown to the left. And putting them together, you might want to consider put this patient on statin therapy because you need to lower their LDL, according to the guideline here, by 30 to 49%. If you're still in doubt, your patient is in doubt, the recommendation is over there to do for these patients coronary calcium scoring. So let's take a look at this case risk-enhancing factor. There are a bunch of them, and I've highlighted for you the ones that this patient has. So she has family history of premature cardiovascular disease. She has evidence of metabolic syndrome. I told you she has impaired fasting, her waist circumference, she has high triglyceride, she is high risk and ethnic background, being from the Gulf region, and she has persistent elevated triglyceride. And according to the European guideline, she has a score risk of 3%, so she falls into the moderate risk group. So her target LDL, according to the guidelines, should be actually below 100 milligrams per deciliter. What about our guidelines, the Middle East, we have published this guideline back in 21, and the way we grouped our patients, we have a bit different from the European guidelines. So we have the extreme group, very high, moderate, and low. We use the Q risk to risk stratify our patients, and I've highlighted for you this patient, Wafa. She falls into the high risk category according to our guideline. She has metabolic syndrome and a Q risk score of 4%. We are a bit aggressive because according to this group, we target LDL below 70. The reason why, because from the epidemiological studies, we have found that the risk of coronary events or CVD events in our area and population is actually 10 years earlier compared to the Western population. So is statin necessary in this patient? Yep, yes. I've showed you like 3 guidelines. What is the acceptable or target LDL for this patient? As we said, 30% to 49 or 50% reduction, or achieving a target LDL cholesterol below 100 if you want to follow the European guideline, or below 70 according to our guidelines. How would you address the patient's statin-related safety? And this is what you face in your clinical practice. Now, number 1, she mentioned about diabetes, risk of diabetes. And my dear colleagues, they have shown you from the previous slides today and yesterday that there is a slight risk of diabetes. And actually, the risk of diabetes is like 0.2% per year with statin therapy. And as you can see, the risk is highest with the high-intensity statins, such as atorvastatin, rosuvastatin, and simvastatin. You need to address that and tell the patient that there is a risk, but the risk is not very high and it's minimum. And if we look at the statin-associated side effects from real-world evidence, for example, the PRIMO study, you can see that the risk of myalgia was about 10.5%, with 2% only of patients stopped due to myalgia. And what about the common reasons for statin discontinuation listed over here, as you can see? Yes, again, side effects are one of the leading factors for patients discontinuing statin therapy. But with proper education, you can see that more than 60% of patients, they are willing to retry to go back on statin therapy. And it's very important looking at when you combine a measure of statin intensity and statin adherence, looking at the area under the curve, and looking to the left over here, the cardiovascular risk. Of course, the optimum would be having your patient on high-intensity statin and full adherence. But look at this in the middle. If your patient is even on low-intensity statin but being adherent, you could achieve some benefit over there. Similarly, for the LDL reduction, of course, the best is having high intensity and fully adherent on the statin, but you could achieve some LDL lowering even if you put your patient on low-intensity statin and being adherent. So these are factors to consider in your statin intolerant patient or patients who are resisting high doses of statin. So the first question you would ask yourself, is the muscle pain or ache really statin intolerance? Or is it a nocebo effect? So Professor Benach talked about the nocebo effect yesterday. So it is actually a decrease in benefit or new onset or worsening of adverse effects, usually subjective, and it's usually due to expectation of harm associated with the treatment. Very important to note that factors favoring clinical diagnosis of statin-related myopathy are symmetrical proximal muscle pain or weakness, symptoms beginning 2 to 4 weeks after statin initiation, resolution of symptoms within 2 weeks of discontinuation, symptoms returning within 2 weeks after reintroducing statin, and symptoms occurring with 2 or more different statins, at least one of which is prescribed at the lowest dose. So that would be probably statin-related. And this is adopted from the NHS UK. There are different scoring systems to detect really statin-related side effects, but these are really, in general, the approaches. Most of you know you need to sort of individualize. You can start with low-dose statin. You can do de-challenging, stopping the statin, and re-challenging again. You can use different statins. You can try long-acting statins, such as rosuvastatin, atorvastatin, and space them, like put the patient on once or twice a week or start from the beginning with lower intensity statin plus ezetimibe. That might give you some benefit over there. So the nocebo effect, I always tell my patients about this trial, honestly. I tell them that this is a Samson trial, self-assessment method of side effects or the nocebo, and it was conducted on patients. And surprisingly, look at this. In patients who had discontinued statin therapy because of side effects, 90% of the symptoms burden elicited by statin challenge was also elicited by placebo. And when I tell these to the patients, and specifically in this trial, when the patients were told about that, more than 50% restarted their statin once shown that symptoms not related to statin dosing. So a great deal of nocebo over there. Liver function, very important. Yesterday, Professor Benach told you about it. Do not exclude patients from statin therapy who have slightly elevated liver enzymes, as long as they are below 3 times above normal. Do not exclude patients who have fatty liver disease or NAFLD. Even if they're actually, as a matter of fact, these patients would benefit from statin therapy. Only in the case of acute hepatic injury, you don't give statins. So, shared decision making, and this is what I do in the clinic. I always tell this to my patients, and I show them my hands. The risk-benefit ratio. So, these are based on multiple clinical trials. So, you are looking at benefits per 10,000 people being on statin for 5 years, and the risk for 10,000 people being on statin for 5 years. So the benefits are you are avoiding 1,000 events, 1,000 cardiovascular events in patients with established cardiovascular disease, and you're avoiding 500 events in patients without established cardiovascular disease. On the other hand, the risk of myopathy is only 5 events probably, hemorrhagic stroke maybe 5 to 10, diabetes cases 50 to 100. So this is the way you look at it with your patient. So Ms. Wafa was actually switched to pitavastatin, and like Professor Benach was showing you, the choice of this statin, because she was worried about diabetes and she has impaired fasting, so she's pre-diabetic, and pitavastatin actually would have no effect on the diabetes, and actually it might even improve glycemic control. So pitavastatin was given to this patient as a choice, and if you don't have pitavastatin access, in the middle, because this patient would need somewhere moderate intensity statin, these are your choices to give this patient as an alternative to the pravastatin, because she's currently on pravastatin, which is low intensity statin, and it's not bringing her to the target. So the take-home messages from case 1, risk estimator or estimators, calculators alone could underestimate an individual risk. Including risk-enhancing factors provide a more accurate assessment of overall cardiovascular risk. The presence of only one risk-enhancing factor can elevate the relative risk of ASCVD by approximately 1.25 to 6-fold. Measure of coronary calcium scoring and carotid intimal median thickness could be a tool to further define statin use. We now have 3+ decades of favorable statin outcome trials, including safety data. This is useful information when discussing risk-benefit of statin therapy with patients. Engaging the patient in shared decision-making is especially helpful in patients who feel fine but are increased cardiovascular risk or have experienced statin-related adverse events. Case 2. Now, case 2 is going to be about secondary prevention and challenges to achieve strict target. So my colleagues were showing you achieving very strict targets in these patients is very important. So Mr. Zahid is a 67-year-old gentleman, presents for a 6-week follow-up after recent NSTEMI, underwent PCI of RCA. Past medical history, peripheral artery disease, so not only coronary, he has also peripheral artery disease with symptomatic claudication, diabetes, and hypertension. He smokes, reduced 1 pack daily prior to ACAC, now down to 3 cigarettes daily. Family history, father died with acute MI at age 54, hypertension, diabetes, high cholesterol, mother breast cancer, hypertension, high cholesterol, brother hypertension, PCI to LAD at age 49, high cholesterol, pre-diabetes, smoker. So it looks like it's a family of patients with FH and high cardiovascular events. So his fasting blood glucose is 122, total cholesterol 188, HDL 42, triglycerides 135, LDL 119, and his non-HDL is 146. Okay, so what is the next step in the management for this patient? So the first option is patient on high-intensity statins. So the patient is actually on his medications. He's on rosuvastatin 40 milligram plus ezetimibe 10 milligram. So he is already on combination therapy, rosuva 40, which is very high-intensity statin, and ezetimibe 10 milligram. So patient is on high-intensity statin and ezetimibe, no changes indicated, or should you add bempedoic acid 180 milligram daily, or change to atorvastatin 80 milligram daily, or add inclisiran, or add PCSK9 monoclonal antibody. So to answer this, there is almost 20% of patients who had MI. They are likely to have another event very soon after the first event. And despite maximum statin given to these patients, there is still 70% residual risk. The residual risk could be from not achieving LDL target. It could be some from inflammatory markers with high CRP. It could be simply thrombotic, triglycerides, Lp(a), or even poor glycemic control. And we know from the talks that we have heard this morning that the lower we go, the better from the previous, from the trials. So if we look at this patient, particularly in accordance to the European guideline, our patient falls into the very high risk category. He had already an event, and he had a stent, and he has also peripheral artery disease. So his LDL target should be actually below 55, and he is at 119. And according to the Middle East guideline, he falls under the extreme group, and we have a similar target, which is below 55 LDL. And looking at the American guidelines, again, similarly, they suggest the same target. So now here, the pathway shows you that if the patient is already on high-intensity statin ezetimibe, your choice is to go with PCSK9 inhibitor. And what do we know about PCSK9 inhibitor? For example, alirocumab, when it's given at the time of NSTEMI, it significantly reduced the LDL. Look at the wonderful effect. Within hours, when you add alirocumab, the LDL comes down by 30 milligram per deciliter. Within just a couple of weeks, the LDL comes down by 64 milligram per deciliter. Alirocumab also reduced first and subsequent non-fatal cardiovascular events, and also it reduced the coronary plaque and regression in patients with acute MI. So it's very, very important to introduce these agents as early as possible. Similarly, evolocumab, within 3 days of the event, there is a significant reduction in LDL cholesterol. Not only that, evolocumab, 80% reduction in major coronary events, 23% reduction for additional PCI, and 24% reduction in PCI at de novo lesions. And also, evolocumab is able to stabilize the fibrous cap thickness. So, in these patients, it's very important, high and very high risk. Like Dr. Wiley said, there is no point of just giving these patients, statin and ezetimibe. You need to go in these patients really aggressive and start from the beginning, even triple therapy, as seen in this case. So, again, as we said, so the first choice is the wrong one. You cannot just keep the patient on the same combination and continue as it is. Would you go and change him to atorvastatin 80 milligram? Why would you do that? Like Professor Benachtel said, you cannot downgrade your patient. You cannot just go lower doses. 80 milligram atorva is actually lower in efficacy compared to Rosuva 40 milligram and ezetimibe 10 milligram. So these choices are out. You could still go with pempidoic acid or inclisiran, but now because we have evidence, the guidelines are telling you the first choice after that is PCSK9 inhibitor because you have the cardiovascular outcome evidence as I showed you. So Mr. Zahid was prescribed alirocumab 140 milligram every 14 days. After several doses, he developed runny nose and reaction at the injection site, as well as expressed difficulty with self-injection and having frequent injections every 14 days. So he discontinued therapy. He didn't like it. He doesn't want to take shots every 14 days. So now what to do? Should we just leave him and keep him on the same Rosuva 40 milligram ezetimibe, or should we consider adding pempidoic acid, or should we change him to atorva 80 milligram, add inclisiran, or change him? He was on alirocumab. Let's try avelumab. So again, we said first choice is wrong, atorva is wrong. Now, what about avelumab? Avelumab is probably not necessarily would give you a local reaction like alirocumab. It doesn't mean if he had with alirocumab, he would have with avelumab. But again, you're doing the same thing. It's a shot that he needs to take every 14 days or once a month. He doesn't want to do that. So you are left with pempidoic acid or inclisiran. So this is what the guidelines are telling you. You go to PCSK9, it doesn't work, or patient doesn't want to use it. Your other option is to go with pempidoic acid or inclisiran, and it's documented there in the guidelines. The speakers talked nicely about pempidoic acid and how pempidoic acid works, and we have, from the clear outcome trial, positive cardiovascular outcome with pempidoic acid, so it gives you some cardiovascular benefit over there as well. So, yeah, why not? Let's do the pempidoic acid because the patient doesn't want to take the shots, the PCSK9 inhibitor shots. So Mr. Zahid was prescribed pempidoic acid, and labs after 12 weeks showed the following, as you can see: total cholesterol 167, HDL 42, triglycerides 130, and LDL came from 119 to 99. So that's only 17% reduction from the baseline. And Mr. Zahid is not happy about taking 3 agents. You could go with fixed combo, which is Rosuva 40 and ezetimibe 10, but this combo was not available. So he was taking 3 oral medications. He's not happy even with that. And are you, as a physician, happy with the LDL level? No. We said this patient is a very high risk. And according to our guideline, extreme risk. He needs to be at LDL cholesterol below 55. So now what to do? We are back to our options. Now I'm giving you some other options. Should we add lomitapide? Should we add inclisiran? Should we just initiate LDL apheresis? So in order to answer that, as we said, this is not an option, the first one. You have an option between these 3. And I think out of these 3, it is clearly stated in the guideline, may consider pempidoic acid or inclisiran. So inclisiran is next on the guideline pathway. The speakers told you about inclisiran, and from the different trials conducted in inclisiran, like the Orion trials, Orion 10 and 11, and the upcoming Victorian, which would show the cardiovascular outcome. So all these trials showed significant reduction in LDL cholesterol from baseline, reaching up to 50%. And the good news about inclisiran, it's easy. It's just only every 6 months. Initially, you need to give 1 shot, and then after 3 months, another shot, and then you carry on every 6 months. So this is like a really ideal one for Mr. Zahid. He doesn't want to have frequent shots. It's just twice a year shot. He was prescribed inclisiran, and labs prior to the second dose at 3 months, beautiful results. So LDL now is at 49. You achieved 50% reduction and your patient is at target. What if you don't have inclisiran? What if you don't have PCSK9 inhibitor? What if you don't have bempedoic acid? What to do? These are the options currently that you may have. Fenofibrate can lower LDL, but in certain subset of patients, you would have some cardiovascular benefit. Colcivilam and niacin, again, side effects, but no CVD benefit. The take-home messages for this case for secondary prevention, strict and very low LDL and non-HDL targets, very important. Potential for additional ACVD risk reduction from additional non-statin, cost consideration for additional non-statin therapies, and patient preference. You have to look at convenience, route of administration, polypharmacy, and other stuff. I want to go to the third case, so I have 10 minutes? Yeah. Okay. I will be fast. So the third case is about hypertriglyceridemia. Miss Maya is a 46-year-old with a past medical history of hyperlipidemia, hypertension, diabetes, obesity. She's concerned about results of recent blood work ordered. She was asymptomatic, denied any recent abdominal pain, nausea, vomiting, stool changes, or change in weight or appetite. Her labs showed triglyceride 405, HDL 36, LDL 68, and ApoB lipoprotein 1,350, A1C 8.6, blood pressure 132/84, and BMI 38.8. She is on metformin 500 twice a day, lisinopril 20 milligram, atorvastatin 80 milligram, plus ezetimibe 10 milligram. She's already on combination therapy. Ms. Maya shared that she did not think she had ever experienced pancreatitis, she denied any surgeries, and she denied drinking alcohol or smoking, but she has poor lifestyle, no diet control, and no exercise. So, what to do apart from controlling her diabetes? What is the next step in the management for this patient because she has hypertriglyceridemia? Patient is on high-density statin, no change indicated. Would you add fibrate? Would you add omega-3? Or would you add PCSK9 inhibitor? So that's a very interesting case that you see with hypertriglyceridemia. Hypertriglyceridemia reflect a different ApoB-containing lipoprotein particles. And it's very important to note that triglyceride, there is increased ACVD risk with high triglyceride. But high triglyceride is a mixed bag. Now I'm showing you a triglyceride, high triglyceride pattern for two different patients, but the same triglyceride level. So a triglyceride of 405 like our patient, but to the left, it shows you smaller particles, and to the right, bigger particles with triglyceride content. So to the left, the cholesterol esters in the particles way higher to the patient on the right. And this is reflected on the ApoB level. So as you can see, the ApoB is very high on the left, but it's lower on the right. So this is more actually atherogenic compared to this one. You have to always correlate your triglyceride with the non-HDL and ApoB. So the clinical benefit of LDL or triglyceride lowering is proportional to the reduction in the number of atherogenic particles. I will skip because there is no time. Now, prominent trial showed that pemafibrate actually didn't do much. It didn't improve cardiovascular outcome, but fenofibrate, as we know from field trial, it showed some cardiovascular benefit, but the benefit was in a small subset of patients who had high triglyceride, low HDL. These are typical metabolic syndrome. So fibrates could be considered. Now, reduced trial, it showed some benefit with icosapent ethyl. Very important. Don't generalize this trial on all omega-3. Not all omega-3 would cause the same benefit. This is only for icosapent ethyl. So you can see that the benefit was independent of TG effect. As a matter of fact, as you can see, even when triglyceride was below 150, there was still benefit. So it's truly not related to the triglyceride as much as it's related to the ApoB-containing lipoproteins or the cholesterol remnants. Miss Maya, she was prescribed fenofibrate. Subsequent lab investigation showed that she's having persistent high creatinine. Probably you're facing this in your clinic. It was not going down. The nephrologist suggested, because the creatinine is not declining, let's just stop the fenofibrate. She was then prescribed 4 grams of omega-3 fatty acid. Ecosapent ethyl was not available. 3 months later, she has GERD, severe GERD, and states that she cannot tolerate the omega-3 anymore. She stopped it. And you face this in clinical practice, unfortunately. Despite all the attempts to improve her glycemic control and lifestyle, she, up to her limits that she can, her triglyceride remained elevated, as well as her non-HDL. Now what to do? She cannot take fibrate, she cannot take omega-3. What is the possible next step? Could be PCSK9 inhibitor? No. Before I take you to the details of the PCSK9 inhibitor, the speakers today spoke about a very important agent, evinacumab. Evinacumab is a monoclonal antibody blocking the ANGPTL3 protein, so thereby blocking the lipoprotein lipase and endothelial lipase. Now, it has FDA approval for homozygous familial hypercholesterolemia. But I want to tell you something. This has not granted an approval yet for high triglyceride, but it does an amazing job, especially in these patients. It lowers actually the triglyceride up to 59% in these patients. Not only that, it lowers the non-HDL up to 45% and remnant cholesterol up to 61%. So really, it's given as an IV once a month. It also reduces fat in the liver, so it reduces fatty liver.
Yeah.
So this patient, you could use fibrate if she can tolerate it. You can use omega-3 fatty acids if they tolerate, no GI side effect. Evinacumab is a promising agent. Sometimes we are using it off-label for such patients. And PCSK9 inhibitors, yes, you can use, because PCSK9 inhibitor can reduce your triglyceride 10 to 15% and non-HDL by 52% and ApoB by 54%. So finally, the take-home messages for case 3 in mild to moderate hypertriglyceridemia, TG reduction should not be used as target for CVD reduction. Triglyceride-rich lipoprotein, which are the remnant cholesterol, which is ApoB and TG, best surrogate for CVD reduction. Only if TG above 500, focus will be on TG reduction to prevent pancreatitis. With that, thank you very much for your attention.
Apologies, our sincere apologies. There will be no Q&A session, and we'll move straight to the next session. But I do encourage you to please approach the speakers if you have any questions. So the next speaker is Professor Khalid Al-Rasadi, Director of Medical Research Center in Sultan Qaboos University and the President of OSCE.
I'm really put here in a very difficult situation. People want to pray, they need to present, so I will try, inshallah, to make it easy for you. So this is my disclosure slide. This is also the disclaimer slide. So we are talking here today about a rare genetic disorder, homozygous familial hypercholesterolemia. Which is really the importance of knowing this disease is mainly related to cardiovascular disease. So we know with homozygous familial hypercholesterolemia, it is a genetic disease causes by mainly 2 gene defect. Estimated prevalence previously 1 to 3 million, but we know that it is now more common, almost 160,000 to 300,000, maybe in our region, although in the Gulf region, we don't have yet some statistics, but we know because of the consanguinity marriage, and we are talking about 2 genes defect here, maybe it is more common. Biochemistry levels are exceeding more than 10 times LDL cholesterol. Clinical feature, you will find all those typical xanthomas and thalassemas, and usually these patients, if they are not picked up early, treated aggressively early, they can develop cardiovascular disease at an early age. Who can see familial hypercholesterolemia? Any one of you can see familial hypercholesterolemia. Cardiologist, radiologist, dermatologist, family physician, genetist, laboratory, pharmacologist, anyone can see familial hypercalcemia, because usually this severe form usually present with all these, it's easy detectable, so, and you can refer this patient. Prevalence, like I told you, almost more than 30,000 people worldwide homozygous familial hypercalcemia, and you can see there, how it is distributed. In our region, not yet we have a statistics for homozygous familial. We have a good statistics for heterozygous FH, and this is our next step, maybe to concentrate more on looking at that. So in Arab countries, it's already, there is this literature from Dalal al-Habib showing there is a spectrum of familial hypercholesteremia in the Arab country, and you can see very well there's like around 51 mutation, 47 in the LDL receptor gene. This is where you put your money in, and almost 20 are new gene, unique to the region. This is why we are not same, not similar to what we see in the Western or Asian. We have some unique feature there. And as I told you, consanguinity is very high in our region, and this is what we are suspecting, that maybe homozygous familial hypercalcemia cases here are more. We have our Gulf familial hypercholesterolemia registry, 1 in 112, very high prevalence, more higher than what's seen in the Western and Asian, and we believe homozygous will be similar, and this is what we need to do next step. Despite saying that, homozygous related to severe atherosclerotic cardiovascular disease, there is still low estimated prevalence in many countries, and it is still also underdiagnosed and undertreated. So genetically, either two genes from the same single gene, two mutation from the same single gene, or two mutation from two different genes. So either you call it biallelic semi-dominant or biallelic semi-dominant with other genes. So there are variation, and there's also the autosomal recessive variants. So although we say that genetic testing is to confirm the diagnosis of either heterozygous or homozygous familial hypercholesteremia, but we have seen some cases, with negative genotypes. So do we discard them that they are not FH? No, they are still an FH, but they could have this other molecular etiology, maybe new genes, maybe a mutation that is not detected by the normal sequencing, and you need to do whole exome or whole genome sequencing and so on. So negative does not rule. The recent European atherosclerosis for diagnosis of homozygous familial hypercholesteremia says specifically you have to have an LDL cholesterol untreated above 10 or above 400 milligram per deciliter, and additional criteria, again with xanthomas and also genetic criteria, but again, genetic criteria, if it is not done or if it is negative, still you go with clinical diagnosis. The most important really to look at the LDL cholesterol level in this patient. We know that there is a variation between the LDL cholesterol level and the residual LDL receptor activity. So the higher the LDL cholesterol level, you will expect that the LDL cholesterol receptor on the liver will be low. And this is really very important to know, because this will be prediction for response to therapeutic intervention. We know that compared to the normal patients with low risk and compared to the heterozygous familial hypercholesteremia, on the left, the line, those patients with homozygous familial hypercholesteremia, usually they accumulate a cholesterol burden in their blood vessels earlier and more in accelerated form than what we see again in normal or in heterozygous FH. This is why when they develop atherosclerosis, usually they develop it at an early age, 20 years, compared to patient with heterozygous, usually at around 50 years, and normally at 80 years. So this is really very important to know. Why? Because, again, we need to detect those cases earlier. We need to aggressively treat them earlier to prevent this burden of LDL cholesterol precipitated in their circulation. So, and literature are full of evidence, if these patients are on lipid-lowering therapy, combination therapy, then their survival rate will improve, will be better compared to those who are untreated or detected at a later stage. So what is the management plan? So a patient should be referred to a specialized center, because like I told you, this is rare condition, genetic disorder, and it needs a multidisciplinary team really to manage these patients. Cardiologist, a pediatrician, a lipidologist, nutritionist, a genetic counselor, and so on. So very, very important really to refer them to a specialized center. So they need, this either invasive or non-invasive radiological investigation to see the burden of the disease, not only in cardiac, but also in their carotid, to reduce also the risk of stroke in this patient. So what is the treatment pathway? And this is really very important slide. And I'm sure my colleagues, Manakh and Dr. Nisreen, Dr. Waili had referred to this. Single treatment with this patient, homozygous, will not be effective. Forgot about putting them only on statin and ezetimibe, because we know they will not, respond, or maybe will have, a small response. So combination therapy from the beginning for this patient is very, very important. So very, very important to put that in your mind. Of course, with LDL apheresis, if it is available, that will be very important. Lifestyle measures, dietary and smoking cessation is very important for this patient. You look at the target, but now you are dealing here with a genetic disease, which is usually resistance, to therapeutic modalities. So although we said, we would like this patient, their LDL cholesterol to be below 1.8, but believe me, in clinical practice, it's really difficult even with combination therapy. So this is why we should not stop there. We should try our best really for aggressively treating these patients. So you see the European atherosclerosis algorithm for the treatment. Always start with statin and ezetimibe. If it is not enough, add PCSK9. If it is not enough that the PCSK9 does not reduce the LDL cholesterol more than 15%, then most likely the residual activity in this patient is really low, and they will not benefit from PCSK9 or statin and ezetimibe. And in this case, you have either the lomitibide or ANGPTL3, or if apheresis also is present, that will be a good option for this patient. So look at this. This is very, very beautiful, slide, really summarizing that, the relationship between the LDL receptor activity and the response to treatment. So we know that with statin, ezetimibe, or PCSK9, you see almost, if these patients have a good LDL receptor on their liver remaining, the response will be between 20, 50, 60%. But if the receptors are almost 0%, then the response is very, very weak, 25%, and in terms of PCSK9, 30%. So it's really very low. So you should not really waste your time just putting those patients on statin and ezetimibe or even PCSK9. But the best therapy for these patients, if their LDL receptor function is really low, almost 0%, lomitibide, ANGPTL3, and LDL apheresis will be the best. You can see that, so with activity or even without activity, the response to treatment almost the same, 30 to 40%, depend on the genetic variants in these patients. So Ivlokumab has been tested in patients with homozygous familial hypercholesterolemia, and also we have a pediatric cases as well. You can see that those who have still residual activity, their LDL cholesterol can be reduced up to 30%. How about apheresis? It's an excellent therapy, but the problem with apheresis, Dr. Waili have highlighted that it's an invasive. The patient have to come weekly or every 2 weeks for good therapy, and usually the LDL cholesterol go back. So the interval level usually is still not adequate, and you have still to put these patients on other therapy. Liver transplantation, we have an excellent, literature review from Professor Muhammad al-Dubai from Saudi Arabia. They had concluded that even with liver transplantation, still the LDL cholesterol will be high in this patient. Still, they have to be on therapy. So it is not really a good option for this patient. It will not treat the problem. Ivlokumab, I think it had been highlighted by Dr. Nisreen, Khalid, and Professor Banach. Ivlokumab, it's a monoclonal antibody, inhibit the ANGPTL3. So you are wondering if there is no LDL receptor activity in this patient, how Ivlokumab will work on this patient. Still, we don't understand, but we believe that there is another indirect way of clearing other than the LDL receptor, which can be activated by inhibiting the ANGPTL3. So this is, again, one of the mechanisms suggested how this medication work independently from the LDL receptor. And you can see it's an IV infusion every 4 weeks, and it can reduce the LDL cholesterol up to 50% again. Lomitibide, it's work in the liver, inhibit this mitochondrial transfer protein, so it inhibits the association between the apolipoprotein B100 and the LDL particles or the VLDL particles. So it inhibits the production of VLDL cholesterol. And in study in phase 3, it has been shown that it can reduce the LDL cholesterol up to 40%. This is when looking at the intention to treat, and the overall almost more than that, almost up to 60%. So how about the achievement of LDL cholesterol? You can see very well that the achievement of below 70 in this patient up to 58%. So adding lomitibide in this severe genetic will definitely help this patient. We have an excellent also literature from Saudi Arabia with the 2 patients on lomitibide, and you can see very well from baseline of 16 they went down to 2.2. This is really a magic. We never have tested this in patients with homozygous familial hypercholesterolemia, and unfortunately when the patient was stopped accessing lomitibide, see how much the LDL cholesterol, it went back to 22. So, these patients, they need this access to this treatment because this is a safe life treatment. GI side effect, we know that it can increase with the dose and if the patient is not compliant on diet, but this is again minimum in this patient compared to the benefit that they have. Liver toxicity again is minimum, and you have really to follow up these patients with either ultrasound or MRI. I will skip this. How about pediatric homozygous familial hypercholesterolemia? Also, it have been shown in a multi-center study with different dosage. that it can reduce the LDL cholesterol in these patients up to 53%. Those in the age of 5 to 10, and those aged from 11 to 17 up to 51%. And reaching the target is more than 42% in these patients. So this is really very useful. Safety finding, even in pediatric, again, mainly GI side effects, but these pediatric patients have to be taught how to be more adherent to lipid-containing diet. So this is the final slide. So this was, a global call for, detecting these patients with familial hypercholestemia, especially the severe form, the homozygous familial hypercholestemia. We were part of that. So the main thing is really screening for these patients, increasing community and also scientific awareness of this disease. Early diagnosis, early treatment is very, very important. So with this, I will stop and thank you very much.